We're at the AATS in Toronto, Canada, and I'm here with an esteemed group of leaders in our field to talk about low-risk TAVRs and the implications to the future of our field. I have Dr. Lamelas, Dr. Reardon, Dr. Bavaria, Dr. Mack, Dr. Thorani, and Dr. Sheeman. I want to first start off and ask Dr. Mack to just quickly summarize the P3 low-risk results for the crowd.
Sure. The Partner 3 trial randomized 1,000 patients that were at low risk for surgery between TAVR and surgical aortic valve replacement with a balloon expandable valve. The mean STS was 1.9 in this group, and the primary endpoint was a composite of all-cause death, stroke, and rehospitalization at 1 year. And the findings of the trial is that TAVR was superior to surgery for that composite endpoint. All components of the endpoint were also directionally in favor of TAVR compared to surgery. And it's not because surgery did bad. Surgery did great. The 30-day mortality was 1.1% with a predicted of 1.9. It's just despite how good surgery was, TAVR was even better.
And Dr. Reardon, can you give us a summary of the Medtronic low-risk trial?
Sure. We randomized 1,468 patients between the self-expanding valve and surgery. We used a primary endpoint of all-cause mortality or disabling stroke. Now, because we were going to have fewer events by not having hospitalization, we used a Bayesian analysis, which allowed us to give a 2-year endpoint but have an early interim analysis, which we did win. And we found that we were non-inferior to surgery for all-cause mortality or disabling stroke. Now, if we take the over 800 that we had available with full 1-year data and applied standard frequency statistics, we found that for a composite endpoint of all-cause mortality, disabling stroke, or heart failure hospitalization, that TAVR was favored over surgery. So it was really interesting to see that these trials lined up. All the secondary endpoints were in favor of TAVR also.
Dr. Bavaria and Dr. Thorani, can you comment on some unique strengths of both of these trials?
Go ahead.
First of all, I think that it's remarkable that in this day and age, in over 2017 to 2018, we're able to do a randomized trial at what we said that we couldn't do in valve surgery in the past. We actually were able to do a large, well-controlled randomized trial within almost 100 centers between the two trials, and we're able to really look at very adjudicated, echo-derived, and clinical outcomes. We haven't done that before. We've done it in high-risk patients. We've done it in medium-risk patients. But when we look at the population for surgeons, over 80% of all patients that surgeons operate are in a low-risk category. So I think what we've done is taken a very important population and we've dissected this with a randomized trial that surgeons, quite honestly, haven't done over the last 30 years. And I'm proud for really the investigators for doing a very well-conducted trials. Joe?
Yeah, I mean, I agree. These were excellent trials. The FDA should be commended as well as the sponsors. And they were randomized very appropriately. These were very good trials. The data is very strong. Now, the data is only out to 1 year. And frankly, I was a little bit surprised that the FDA gave a 1-year endpoint instead of a 2-year endpoint like they did in intermediate risk. But there's no question that the trials were well done. And the fact of the matter is that the newer generation TAVR devices, because both of them were mostly 3rd generation TAVR devices, are quite good. And so
I do want to say one thing though. There were patients who had high calcium burdens that were thrown out of both trials. Bicuspid valve patients were thrown out of both trials. They had their separate registries, but they're not part of the randomized trials. So I think that's an important adjunct to keep in mind, that this isn't all the patients we operate on, a subset of the patients.
So that touches my next question. I was hoping Dr. Lamelas and Dr. Sheeman can comment on what are some potential unique weaknesses of these low-risk trials?
Well, that's exactly what was discussed. I mean, they don't include the patients that have multi-valve pathology, as well as patients that have coronary disease. Obviously, the bicuspid valves are a different group of patients. Those that have significant calcium invading the left ventricular outflow tract. So there's still a large subset of patients that are not being addressed. I mean, I agree with the low-risk, patients that fall into that category that are optimal candidates for a TAVR. Those would benefit. But again, I think we're missing a large group of patients that will benefit from a surgical aortic valve replacement.
Yeah, the points I'd like to make is that The strength of the randomized clinical trial is very powerful and very influential in guidelines in medicine. But as has already been said, that who was excluded from the trial is very important to know. So there's always bias getting in, but no bias once you get in and are selected, because then you're randomized. The second thing is as Dr. Bavaria said, length of follow-up. 1 year is a very short period of time, and we've seen many other trials as you continue following patients with cardiovascular disease over the years. You don't see the separation until you get several years out. And the third thing is to keep in mind that low risk is not young age. We know very little about durability of these valves over time because all the historical trials were in such high-risk patients. They never had biological lifespans that allowed us to really look at durability over time. So that question is still out to pasture. So as we look at low-risk patients being incorporated into the use of TAVR technology, we need to go ahead and be sure to realize age is still going to be a big question mark in our mind.
But despite all that, the fact of the matter is these valves, the TAVR valves, are outstanding, and they work very well. And it's basically as simple as that.
So I'd just add a couple things. One is the reason a 1 year instead of a 2 year endpoint was chosen is because looking at the intermediate trials, there were virtually no events that happened between 1 and 2 years. So there was no advantage to going to a 2 year. Secondly, all patients in both trials will be followed annually for 10 years. So yeah, the primary endpoint was 1 year, but we will know the questions of durability, relative and absolute, by 10-year follow-up in all patients, which would be the first time we even had that in surgery. And then thirdly, about a third of the patients in the Partner 3 trial were excluded for anatomic reasons such as low-lying coronary arteries, bicuspid valve, and left ventricular outflow tract calcium.
Don't you also think that having the CT scans, which is the first time that we've done this in over 400 or 500 patients between the two trials, will give us some insight on what's going to happen to these valves? We haven't done that in surgery either. So having some CT, which is part of the studies of both studies, will be very instrumental in what we think will be potentially structural valve deterioration down the road, the whole aspect of thrombus.
One other point is it's different, a low-risk patient who's 50 years old and a low-risk patient who's 80 years old. So I mean, that's one thing that we have to consider moving forward as well.
I think that's really important too, because the average age for the patients in the trials were in their 70s, but we really don't know what the outcomes are for patients in the mid-70s. This is going to be a little bit more open-ended. After the results of the trials, I came back and did a minimally invasive AVR, and I updated my cardiologist, and the very first thing the cardiologist said was, why didn't the patient get a TAVR? Is there a future for us now to have to justify Saveur? Are we going to have to justify having to do Saveurs in the future?
Well,
I'll leave that open.
We shouldn't be
That's
the
an
one
easy question, Tom. Yeah.
we shouldn't be the one to justify it. It's a matter of the heart team. So if we really embrace the heart team concept, which is both surgeon and cardiologist, and maybe even thinking of ourselves as the interventional cardiac surgeon, because we're involved in the procedure also, I think that justification becomes easier instead of just advocating for what was done by being the surgeon alone.
But Richard, not every surgical patient, every TAVR patient is being seen by a cardiologist and surgeon. Not every surgical patient is being seen by a cardiologist ahead of time. Let's just be honest and frank about that. And so, Tom, are you saying then that we should have every surgical patient seen by an interventional cardiologist? Because then that's a paradigm change, and I think that's the problem.
No, what I think he's saying is that for surgeons to stay relevant, you need to provide an alternative technique as opposed to a full sternotomy. And I truly believe that a lesser invasive approach is very competitive with a transcatheter valve. And the only difference is it's technique versus technology. So most surgeons could be trained to do a TAVR. Not every surgeon is going to be trained to do a minimally invasive aortic valve replacement, especially in a complex valve.
We have a paper on tomorrow on causes of death and low risk, and we're going to look at the right anterior thoracotomies. The minimally invasive numbers are going way up, Joe.
Right.
You should come. You'll enjoy the paper. You'll like some of the results. I mean, I personally think that once low risk is approved, if you have a patient that you're going to consider for a bioprosthetic valve, it should be part of the conversation. Not that everybody should get one by any stretch, but it should be part of the conversation.
Conversation about the surgeon.
But the surgeon should talk about it. The surgeon should, and I do talk to my patients about it. There are many, many people that are going to still be far more appropriate for surgery.
Historically, in the past, we had to go through the heart team to to get patients to qualify for TAVR. I suspect that it might be the other way around, where we're going to have to get patients to qualify for Saveur. That's the vibe that I'm getting from our cardiologists out there.
Well, I think you may be right, and I don't know whether, historically, cardiologists would present a patient for surgical aortic valve without having to go through a heart team concept, as Vino just talked about. That's an historical precedent that's been around for a long time. I doubt that it's going to go away right away. So the bottom line there is that to answer the question that you had is that there's a lot of nuances to these trials, and you probably need to educate a lot of the cardiologists, the clinical cardiologists who might not know those nuances.
Well, I think you should educate the surgeons out there that don't follow this trial, because, as Richard pointed out, randomized trials apply only to the population that was tested, not to everybody in the world. And if surgeons want to have a legitimate conversation, they need to understand what these trials tested. They both were very similar trials with very similar outcomes, but there's also people that were 73 and a half, 74 years old. We excluded about 225 out of 1,468. We didn't take everybody. There's anatomic exclusions or bicuspid exclusions. So I think it would behoove surgeons that are valve surgeons to understand these trials, because their patients are probably going to come in asking for TAVR.
Sure.
And if you want to tell them they need an operation, you need to tell them why they're better off with an operation.
And we should always approach the discussion from the patient's point of view. They're always going to choose the least invasive, lowest pain threshold, quickest recovery type of procedure.
Right, so would you.
So TAVR is going to be what they want. Then I think, it's a matter of knowing the data, knowing the information, and honestly presenting that alternative to them. I agree that a minimally invasive or minimal access approach should be the surgical standard of care for single valve disease, aortic valve stenosis. But, there's a lot still to be learned. One of the areas I just want to put on the table of interest to me is, I think we've all been impressed, annular size for annular size. The gradients are extremely low. A Saveur never totally restores a patient to a normal age-adjusted, sex-adjusted mortality curve. And it may be by the lack of mass regression. Some subset of patients that still have mismatch. I mean, the TAVR valve is phenomenal that way.
But on the other hand, the one thing that was interesting to me, and it wasn't statistically significant, but one of the things that interested me for the first time with these two trials was that the Saveur valves were actually better than the from a standpoint of gradient.
That's only one trial, because in self-expanding, Saveur valves have never beat them. Right. Although our Saveur valves were much bigger and much better and had EOAs of about 2, which would make almost any surgeon better. The other thing that I see, and I haven't talked to Mike or Marty about this, but the number of minimally invasive cases in between high and intermediate and low is going up. Saveur is making surgeons better. It's we're no longer competing against this other surgery.
TAVR's making surgery.
TAVR's making surgery better, because we now have a different competitor on the block, and surgeons have known for a long time our valves weren't big enough. Now people are doing something about it.
I think it's pretty clear patients want the least invasive option. Dr. Mack, something that's important for us is training surgeons to be able to perform TAVRs. How do we train surgeons to be able to perform TAVRs proficiently, not blow up the balloon and stand there and how do we train them to be proficient?
Well, I think there has to be a fundamental shift in the way that we train surgeons for this. There's a lot of surgeons that are proficient in TAVR, including a number of people sitting right here today, but that's not the general sense. And yes, there's surgeons participating in the procedures, but not always as primary operators for the procedure. And this isn't only about TAVR, it's about all structural heart. MitraClip is gaining rapidly, tricuspid, et cetera. So I think there has to be a fundamental shift in the way that we train. So one possibility is a structural heart tract to be able to sit for your certificate for the American Board of Thoracic Surgery. Another possibility is a formal one-year training as interventional cardiologists are doing now, an ACGME fellowship year in structural heart disease. And I think if we're going to be serious players in the structural heart disease space, we've got to do more than we've been doing until now.
Absolutely. We've seen a decrease in Saveur numbers, and that's been published. there's an argument out there that how we're going to train young surgeons or even surgeons to be able to perform Saveurs. Is that going to ever be an issue? Dr. Bavaria, what do you think?
Well, it is going down very slowly. If you look at the TBT data linked with the STS data, which we have, the total number of Saveur procedures is going down ever so slowly. The total number of TAVR procedures is going up astronomically, so the total AVR, aortic valve procedures in the United States of America is dramatically increased. So this is all pretty good stuff. I don't think we're at the level where we're going to have a problem with training of surgeons in Saveur, at least in the next 5 to 10 years. I suppose eventually that could be a problem. Kind of like what happened to vascular surgery, where they went totally endovascular, and now they don't do any open surgery. So I can see that happening. It's not going to happen in the near future, because if you look at all the subcategories of aortic valve replacement, with all the other non-isolated aortic valve replacement, is actually a pretty substantial number.
So if you look at the
when I was a resident under Cooley and DeBakey, they thought my group didn't have any experience and we would never make it, and we did okay. And I think this is a generational thing. Yeah. Young surgeons are going to get trained. Young surgeons are going to do fine.
Yeah, and I also echo what Mike says a little bit more granular. The younger surgeons today, at least they're all TAVR trained. They're all TAVR trained quite substantially, actually, and at least in our system. And they're as good doing TAVR as any interventional cardiologist. I mean, it's really a heart team. And at the younger age group, it's really quite great to see these heart teams working. I'm not talking about attending to attending. I'm talking about fellow to fellow.
I think we do have to look very carefully. The median institution does 23 AVRs a year. The institution for AVR CABG, it's about 13 to 15. So we're going to probably, if you add AVR mitrals and everything else, we're looking at about 40 to 50 AVR procedures per institution as median.
I know, but that's not training institutions.
No, but that includes all institutions, and I think that we're going to have to make sure that our institutions that are training residents and that 80 or 90 centers really have the number of volume to do that. But I think it is something that I worry about after the next 5 years.
One other thing on training, the American Board of Thoracic Surgery has taken a forward-looking stance by now incorporating an actual index case list that's necessary for TAVR exposure during your training program. Now that, at least is a beginning, and every training program has to comply, and everyone sitting their boards has to have those numbers. Then the additional fellowships, year of training, and maybe even certification in structural heart is the next step. I don't think every surgeon is going to have a marketplace to be able to be a TAVR surgeon also, but a subset of people, and everyone on any surgical team needs to have that expertise.
I want to talk about some more controversial topics. Not that the stuff we talked about before wasn't controversial. Dr. Bavaria, very quick summary of the impetus of the upcoming CMS proposals. What was the rationale for revising proposals, and a quick summary of what the proposal might mean to us.
Okay, so the rationale for revising the proposal was based mostly on an access issue. So the reason why the NCD was reopened through CMS was because a number of hospitals in the United States of America did not quite meet the volume standards to be able to have a TAVR program, which was very important to their health systems, and because of that, the NCD was reopened. So it should be clear to everybody that the NCD was reopened because of a perceived access issue in the United States of America. Okay, so now that the NCD was reopened, there were a number of issues that were discussed and formulated by all the stakeholders in the United States as well as CMS. This includes primary volumes for whether you have a maintenance program or a new program, as well as basic or what we call floor volumes. And the second issue was the maintenance of the heart team. And the third, and the heart team, not only about pre and post-operative care, but also about intra-operative execution of the TAVR procedure. And also the last big area was quality metrics and quality measurement through the STS ACC TBT database, which was a mandated database by CMS in 2012. So what happened? Well, the quality metrics and the mandated TBT database is probably going to stay, at least in the original NCD that came out, the proposed NCD that came out of CMS. So that's one big thing there. The second thing is that it's very strong on multidisciplinary heart teams. So nothing much is going to change regarding the MDT, as well as surgeon and interventional cardiologist participation in the procedure. And then the third area is volumes. That's where a big change happened. Frankly, what's going to happen is that we're going to have a greater access to TAVR in the United States of America. This was one of the reasons why the NCD was open in the first place. I don't really have a problem with it personally, and I don't think the organized societies of the STS, ACC, AATS, and SCI have a big problem with it, especially if quality is going to be measured appropriately. So that's kind of the NCD in a nutshell.
It's about a year's work right there, 2 minutes.
Currently, right now, surgeons have to evaluate a patient for a TAVR. There's been dialogue that a cardiologist should evaluate a patient for a Saveur. What are the group's thoughts on that, briefly?
Well, I stated publicly after we did the LowRisk trial that when LowRisk is approved, if you're being considered for a bioprosthetic valve, TAVR has to be in the conversation. And as a surgeon, you should understand the data to talk to it. Not everybody's going to get a TAVR, but if you're being considered for a bioprosthetic valve, it is worth the conversation. Now, so it's the easy points like age, but then there's some finer points that you can bring up. But you need to understand the data. You need to be able to talk to patients about this.
I think that's absolutely true. And the NCD will actually have something of that in there, that discussion in a deep manner regarding aortic stenosis treatment in general. Both Saveur and TAVR is going to be an important component.
So I think that's easy for the people really on this panel that do TAVR and Saveur. I think it's going to be incredibly hard for a surgeon who is not part of the TAVR team to all of a sudden change that paradigm shift. I'm not saying it's going to.
It'll be changed.
I'm not saying I'm not saying that that's right or wrong. I'm saying that will become a difficult pathway, and I'm not sure how to do that for surgeons across the board. How to govern it.
Another current requirement is that a surgeon and cardiologist be involved with the procedure. But do we really need a surgeon and a cardiologist, or should we have just 2 qualified people, 2 surgeons, or maybe 2 cardiologists? What are the group's thoughts on that?
I think you should have a surgeon and a cardiologist. If our focus is how do you have surgeons involved in structural heart disease, I cannot see that going down the road the 2 cardiologists will work together to do it.
I'm interested in Mike's thought on this.
I'm going to pin you down. I know you have a lot of thoughts. But,
Yeah, I think a surgeon needs to continue to be involved with the heart team going forward. I think it's, I think this is a paradigm that's worked, and I don't see any good reason to change it.
Yeah, there are 2 different skill sets and a little bit of a different approach regarding their anatomy and knowledge and other areas, and it's a mixed skill set that actually is better for patient care.
And I think conceptually it's a nice idea, but in the real world, it probably won't work every single day like that.
But in the real world, when you have the surgeon involved with the interventional cardiologist, you both do the procedure together, you both see the results, the outcomes, the pros and cons, you create a dynamic where it's not 2 specialties competing, it's 2 specialties complementing each other.
But it's easier for a surgeon to provide an opinion on a TAVR as opposed to a cardiologist providing an opinion for a surgical approach.
We're gonna wrap up with.
They really won't give surgical approaches. They'll just say, should you have surgery, and they'll leave it to you. Just one final thing about the surgeons. I mean, if you're going to focus on quality, having a surgeon there is helpful when you have to make decisions on the fly. I've seen cardiologists start pushing the iliac vessels because that's the only way they can do it, whereas if you have a surgeon can very easily go to an axillary or carotid or some other access and not get into trouble.
There's another interesting point about this. From the TBT, this is not necessary. There's 2 big data sources that are reasonable. One is the prospective randomized trial, but the other one, especially a mandated big data concept, which is what the TBT database is. And if you look at it, there is still a 2% kind of catastrophic rate across the United States of America. Maybe not in these trials, but 2% across the United States of America. And that's a significant number.
Well, we're doing 60,000, 70,000 cases, that's a lot.
And that's a more significant number if it's applied to the low risk.
Last quick comment, Dr. Sheeman, and we're going to start to wrap up.
Well, I think it's very important for every surgeon to really take the time to read in detail the consensus statement of the multi-society task force. It deals with everything from patient selection, the multidisciplinary team, the TBT registry, measurement of quality. It is an education in itself and the state of the art. And the better informed we are as surgeons, the better we'll be able to serve our patients, the public, and our profession.
And that's published in JTCVS?
JTCVS,
all the major
ACC.
All four.
So I'm gonna wrap up with two questions. We're talking about surgeon involvement. I'm sure the societies and our leadership are doing things behind the scenes. What's happening behind the scenes to make sure that patients are treated correctly and to make sure that surgeons have some teeth in the treating of structural heart disease? I'll have Dr. Bavaria start with that.
Well, I mean, the TAVR NCD process is finishing up, and it's basically what I just said earlier. The TMVR NCD is also being reopened at some point. It's not reopened yet because of the COAPT and mitral FR trials. It'll be very a similar process, and the four societies, both the cardiology societies and the cardiac surgical societies, are all working together to work with CMS to make sure that the heart team is alive and well, and that patient outcomes are front and center.
I would say that not only the public comment period in which all stakeholders have had an opportunity to weigh in on the NCD, but all stakeholders have had the open opportunity to meet directly with CMS and express their opinions and rationale why certain things should stay in place based upon strong evidence. So it's been a very open dialogue of all stakeholders with CMS, and CMS has been very open to listening.
And on a practical level, there are courses that are also being developed. There's courses not only for TAVR, but specifically now for mitrals. So there'll be an STS course coming up in August in Chicago that's going to just talk about transcatheter mitral and tricuspid hands-on portions of it. So I think there's a lot of stuff the societies are doing to keep the surgeons involved and give them at least the opportunity, and it's really up to the surgeons themselves to really implement these changes.
Last question as we end. I want to ask each of the panelists, if you can tell me 10 years from now, what do you predict the role is of surgeons in treating patients with structural heart disease? And please limit your response to maybe 20 seconds or so. I'll start with Dr. Lamelas and we'll work our way down.
I think the surgeon definitely needs to stay relevant, needs to embrace the TAVRs, but I still think that the role of the surgeon for the surgical aortic valve is still going to be alive, and also for the complex pathology, because we're going to be treating complications of TAVRs, and there probably will be a lot more challenging than what we're dealing with today.
Dr. Reardon.
Yeah, surgeons are going to be involved. The number of cases are going to go down, but the complexity is going to go up. A really good heart surgeon is going to be worth their weight in gold.
Well, I think that the number of cases actually for aortic and structural valve disease is going to go way up when you talk about the combination of surgical and interventional therapy, and surgeons are going to be a part of that, need to be and are going to be a part of that future.
So I've been hearing my whole career that CABG is going to go away, and here we are. It's still the most common operation that we do. 3 out of 4 revascularizations are done percutaneously, but 1 out of 4 is done CABG. I think the same thing is going to happen here. 10 years from now, 1 out of 4 aortics and 1 out of 4 mitrals will be done surgically, but the overall number of patients treated is going to grow, as Joe said. So it's not going away, and I'm glad I'm not going to be doing it 10 years from now, because there's going to be a lot of TAVR redo routes. They're going to need to be done.
I've done a bunch of those in the last year. So I would say that the relevant surgeon 10 years from now is when the patient sees them is going to be able to do open surgery, transcatheter surgery, and minimally invasive seamlessly, and those are the surgeons that are going to be alive in 10 years.
Well, I agree with all the comments, but my contribution will be that we really have to radically change our training paradigm. We have to prepare the surgeon of the future today, both in structural heart disease and also the ability to deal with complex surgery and to work extremely well in the multidisciplinary team. And I do think as long as we really take the patient's perspective, I mean, I think we're mostly baby boomers sitting here. We're going to be the largest segment, the longest living segment that's going to require health care. Some of us may need TAVRs before we finally pass into the other world. So I think we ought to keep that perspective.
I want to thank our group of panelists who are clear leaders in our field in both surgical aortic valve replacement and transcatheter aortic valve replacement. I know your time is valuable, and we've had a very busy AATS meeting. As we wrap up, I want to thank our viewers here. We're here at the AATS in Toronto, and thank you for viewing this discussion. Hopefully it was educational for you. Thank you.